we are lucky to hear from Dr. Anis on Ptbd. Okay, thank you.
Okay, thank you. Yeah, thank you, Min, for that very kind, overly kind introduction. Can you see my screen?
Yep.
Okay. Assalamualaikum and good morning. So I'm Dr. Anis. I'm from Hospital UITM, and my talk today will be on how to perform a percutaneous transhepatic biliary drainage, or in short, we call it Ptbd. So in this talk, our aim is mainly to cover the 5 W's and H questions with regards to Ptbd. That is, what is Ptbd? Who would need one? Why do they need one? When should we do the Ptbd? Where is the best place to insert it? And most importantly, our main objective is to learn how to perform a Ptbd. Okay, so what is a Ptbd? So it stands for percutaneous transhepatic biliary drainage. It describes a procedure where obstructed bile is drained via a percutaneous approach. It traverses the liver, hence the name transhepatic. In Ptbds, usually we target the peripheral intrahepatic ducts, and the main aim is to relieve or bypass obstruction along the biliary system. So who will benefit from a Ptbd? It's usually done for patients who present with biliary obstruction, and causes of biliary obstruction can be divided into intrahepatic and extrahepatic. So for intrahepatic, it can be conditions such as hepatitis, drug-induced liver injury, primary biliary or sclerosing cholangitis, and infiltrative diseases such as sarcoid or tumors. And extrahepatic causes include benign conditions like gallstones, choledochal cysts, Mersey syndrome, and also fibrotic strictures. So malignancies such as cholangioCA, pancreatic head, and ampullary tumors are also notorious in causing biliary obstruction, particularly in our Asian population. Other less common causes include parasitic cholangiopathy and also inflammatory disease. So why is Ptbd important for patients with biliary obstruction? So in normal patients, the bile continuously produced by the liver parenchyma, which then flows through the right and left intrahepatic ducts into the common hepatic duct, and subsequently it joins the cystic duct to form the common bile duct. And more distally, the CBD then joins with the pancreatic duct near the pancreatic head just before joining the duodenum at the ampulla. So in biliary obstruction, the bile disruption can happen at any level along the path from the liver to the duodenum, and these patients often present with abnormal liver enzymes, for example, like the bilirubin or the ALP will be sky high, causing jaundice, pruritus, and also bilirubin. So the incidence of complications is usually proportional to the duration and intensity of the patient's jaundice. So in a high-grade biliary obstruction, cell death can happen after about a month, and if it's not relieved, it can cause secondary biliary cirrhosis. And the commonest complication is acute cholangitis. So when there's obstruction, the bile, which is normally it's sterile, and when it's obstructed, then it easily becomes infected, and this can eventually cause biliary strictures. Then usually you'll get a concomitant increase in the biliary pressure as well. So this can cause bacteremia, and then it may progress further to septic shock and death. So biliary obstruction can also cause fat malabsorption and steatorrhea. So it results in poor absorption of the fat-soluble vitamins A, D, E, K. So this can then lead to more serious disorders such as night blindness, neuromuscular weakness, and also blood coagulation disorders. Other organs that may be affected include the kidneys and also the cardiovascular system. So when should we perform a Ptbd? Indications include intrahepatic biliary duct dilatation, which may be due to benign, malignant, or palliative causes. A failed ERCP is another common indication. Cholangitis and infected bile is another indication, together with traumatic or iatrogenic bile duct injuries. Sometimes the Ptbd is inserted to facilitate intraductal procedures such as intraductal biopsies or intraductal tumor ablations. As for contraindications, they usually include uncorrectable coagulopathy, ascites, aspirin use, and also hemodynamic instability. So Ptbd is usually performed in an IR suite with an angiography machine, ultrasound machine, and also monitoring equipment. Sometimes sedation or GA equipment might be needed depending on the patient's clinical condition. And of course, you would need your IR equipment trolley. So in order to perform a Ptbd, you will need to understand the following. Firstly, pre-procedure preparation, IR equipment that you need, preliminary assessment, procedural techniques, and also complications related to Ptbd. So for pre-procedure preparation, ensure that you always review the patient's previous imaging if it's available. Check the routine bloods and correct any abnormalities. Nowadays, during times of pandemic, COVID swab is always a must. Make sure that the patient understands what is going on and signs an informed consent. IV access is essential mainly for hydration or medication, and ensure that the patients undergoing Ptbd receive prophylactic antibiotics prior. Occasionally, sedation and analgesia may be needed, especially if the patient is restless or anxious. Okay, now let's briefly go through the equipment needed. Okay, so nowadays we commonly use this set called acoustic. It's an acoustic set for Ptbd. So this set consists of a 21 gauge needle with stylet, an 018 nitinol wire, coaxial introducer sheath with a locking cannula, and an 035 3mmG guide wire. Diagnostic catheters, there's various. It all depends on the patient's anatomy and also the user preference. For the drainage catheters, you can use either a ring biliary or a pigtail drainage catheter. Later on, I'll show you a video showing the rest of all the equipment. Okay. For preliminary assessment, always review patient's previous imaging and perform a preliminary ultrasound to confirm the patient's latest finding and to plan your approach. So decide which imaging modality you want to use and which side you would like to puncture, whether it's going to be the right side or the left side, which segment you're targeting, whether you want to puncture an anterior or posterior duct. Okay, so then position the patient. Usually patient will be in a supine position with the right arm abducted on an arm board. So don't abduct more than 90 degrees to avoid brachial plexus injury, particularly if the patient is under GA, because they won't be able to tell whether they're having pain. Ensure that the C-arm can rotate freely around the patient at the level of the liver. And then you can start prepping the patient's skin. Be very generous. Cover from the nipple to the iliac crest and medially from the epigastric region to the right lateral abdominal wall. So then you can place a sterile drape over the patient. So using ultrasound, you target the duct that you want to puncture. So for the right lobe, usually segment 6 posterior ducts are preferable, and for the left lobe, segment 3 is preferred. So you want to inject the local anesthesia from the skin down to the liver capsule. Don't puncture the LA through the liver capsule or into the liver parenchyma. Okay, so then you make this small skin nick and perform blunt dissection. Insert the puncture needle. And once within the ducts, you can remove the stylet and wait for the bile outflow. It's usually greenish or brownish in color, and it's usually thick and sticky. If you happen to get if you get blood backflow, you can remove the needle and reattempt the puncture. So once you're within the duct, perform a cholangiogram, and based on the contrast flow, you can assess and confirm where the needle tip position is. So if it's in the ducts, normally the contrast will clear centrally, slowly, with no staining. If it's in the portal vein or hepatic artery, the contrast will clear towards the periphery with parenchymal staining in the periphery. But if the needle tip is in the hepatic vein, the contrast will clear centrally in the cephalate direction heading towards the head with no staining. Okay, so when you inject the contrast, do it gently and very sparingly, just enough to identify the biliary tree. Because if you over-inject, you can cause cholangitis and also infection. Okay, so next, after the cholangiogram, you can insert the 018 guide wire. So observe the direction of the guide wire and ensure that it follows the biliary anatomy. And once confirmed within the biliary system, stabilize the wire and you can remove the puncture needle. So after removing the needle, you can insert the introducer sheath. And once the sheath is in, unlock the locking cannula and remove the inner part and the 018 guide wire. So now you are left with the 035 outer sheath. You can insert the 035 guide wire. So I usually replace the introducer sheath with a larger 8 French arterial sheath so that the access is more stable. And make sure to dilate the tract to match the sheath size that you want to use. So if you want to use an 8 French, you have to dilate up to 8. If you want to use 10, then you have to dilate up to 10. Okay. So then you have to make sure that you secure the arterial sheath. You can use a plaster or tegaderm to prevent it from getting dislodged during your manipulation. Okay, so then use a diagnostic catheter to cannulate into the CBD. And once you're within, decide where you would like to place the drainage catheter tip. So if your aim of your Ptbd is for external drainage, then it's adequate just to put the tip in the CBD. If you Some patients will need to have both external and internal drainages. So in this situation, you will need to use a drainage catheter with additional side holes that can drain both the proximal and also distal ducts. So how do you prepare a pigtail drainage catheter? I think Dr. Eric has shown earlier, but I can just recap. So firstly, you want to straighten the pigtail catheter tip using its straightener. Then lock the pig up with the puncture needle and straightener. And then lastly, make sure to flush the pigtail catheter with saline before using it. Okay. Just flush there. Okay. So next, you can remove the diagnostic catheter and the arterial sheath, and then you can insert the pigtail catheter over the guide wire. Place the tip at your intended position, then remove cannula and guide wire. So after that, perform a cholangiogram to assess the tip position and to see the contrast flow. Okay. So at the end, you can then connect a three-way stopcock to the drainage catheter. So before wrapping up, make sure that you secure the pigtail catheter to the skin. You can use either a suture or skin fixation device such as a drain lock. Always clean the puncture site and apply a suitable dressing. And lastly, connect the pigtail drain to a drainage bag. Okay, so a bit on Ptbd stents. These are usually used for palliative treatment of bile duct strictures. So stents can be inserted using an antegrade approach through the percutaneous puncture site. So biliary stents are usually self-expandable metallic stents with good radial force to open up the obstruction, and flat ends are good to help prevent stent migration. And biliary stents tend to expand slowly over 24 to 48 hours. So some tips for Ptbd. Normally you want to attempt to puncture as peripheral as possible to reduce risk of puncturing large or main vessels such as the portal vein or hepatic arteries. So if the patient has ascites, it's better to drain the ascites first as the risk of bleeding is usually higher. If the ascites is minimal, it's okay to proceed if the proposed puncture site does not have any fluid, but you need to make sure that only a single puncture is made into the liver capsule. Okay. If the patient keeps moving, consider giving some sedation. Try to time your needle puncture with the patient's breathing rather than to ask the patient to hold their breath. So for me, I tend to puncture the liver capsule when the patient is relaxed in the expiration to prevent misalignment between the abdominal wall and the liver capsule puncture sites. Okay. More tips, avoid injecting air or too much contrast into the bile ducts, as this can obscure your view on ultrasound. So if you inject contrast and your contrast keeps disappearing, it probably means that you are no longer in the ducts. And if the contrast clears towards the periphery, then you're either in the portal or hepatic artery. If the contrast clears centrally and in the cephalic direction, meaning towards the head, means you are in the hepatic vein. And if you inject your contrast, it doesn't seem to go anywhere, it's just staining there, then your needle tip is probably within the liver parenchyma. Okay. So once you've done your cholangiogram and you're unable to advance the wire, recheck your needle position. Use different ultrasound planes to help confirm your tip position. And if your needle puncture angle is too sharp or too acute, you might want to remove the needle and repuncture. Try to make a new skin nick and make it a bit further away so that you will then have a flatter needle insertion angle. Okay. Sometimes, but very rarely you shouldn't actually. This is more like macam last resort lah. You can use a hydrophilic wire, but you need to be careful not to shear off the hydrophilic coating. But for beginners, definitely we don't encourage this lah. Okay. But if you're unable to bypass the obstruction, then you can put an external drain first and reattempt bypass a few days later when the system is less capacious and also less ligamentous. Okay. So if when you're trying to cross the lesion and the patient starts bleeding, it's always best to stop immediately and place an external drain, resuscitate the patient as needed, and monitor the patient closely. So if the patient is stable, you can reattempt maybe 2 or 3 days later. But if the hemophilia is persistent, have a low threshold to perform a CTA to rule out any pseudoaneurysm or any biliary fistula. So sometimes they'll call you and say, Doctor, Ptbd stops draining. So then you'll need to check to see if the catheter has kinked, blocked, or dislodged. Firstly, try to flush with some saline and then perform a PTC to assess the flow again. Okay. Once in a while, these patients will develop rigors on table. So this usually indicates that the patient has developed cholangitis. So in this situation, you have to quickly call the primary team as these patients usually need to be resuscitated. Always quickly double check to see if the patient has received any antibiotics. If not, then you have to give one stat immediately. Okay, then check again if the system is obstructed and you can get access. Immediately place a drain and allow free drainage. So complications of PTBD can be related to access and puncture sites, catheter-related complications, non-vascular, vascular, or bleeding complications. Okay, so now I'd like to share a procedure video so that you have a better overall picture. For this video, I need to thank my IR radiographers, especially Hakima and Fakrul, for preparing this video for me. It's a very beautiful video. So done. Stop share. Can you see the video?
Yep, can.
Okay. Can you hear the audio? So before doing a PTBD, you will always do a preliminary ultrasound to see for the dilated ducts. So we will scan. Normally, we will try to detect segment 6, which is the posterior ducts. So we try to go as peripheral as possible. So we look for the double duct sign. And we check with color. So it doesn't look like there's any color there. So we can try and target these ducts. So today we'll be doing a PTBD. PTBD stands for percutaneous transhepatic biliary drainage. So basically we do it for patients who have obstructive jaundice. And how we do it is we're going to puncture directly percutaneously into the bile ducts into the liver. Okay? But before we start, let me just show you the equipment that we will need to be using. Okay? So firstly, we'll have to clean the patient. Normally we use chlorhexidine and we use gauze to clean the patient. And after cleaning the patient, we'll put in a drape over the patient and we will prepare the ultrasound. Normally we'll use sterile gel and also a sterile ultrasound cover. We will demonstrate to you how to put it on later. We also prepare local anesthesia. So normally we use lignocaine 1%, about 10 mils. We have a disposable blade. We use artery forceps or mosquito for blunt dissection. And we have a 21 gauge puncture needle. It's 21 gauge with 15 centimeters length. Okay. So with that, we have a 018 wire. This is a nitinol wire. 018 nitinol wire. And we also have a introducer sheath. So it comes with a locking cannula. So as you can see here, if I unlock it, it actually has the inner side is 018 and the outer side goes to 035. So we can convert the system from 018 to 035. Okay, so you can lock it there. And this is the 035 guide wire. Normally it's a 3 mmJ. It's got a 3 mmJ tip, which we can straighten with the introducer. Okay, so these are usually the equipment that we need. Other things we also need will be gauze, and we'll need contrast. So normally we use contrast half strength, 50%. So we use this as contrast. We use a plastic galley pot to identify between contrast and saline, and this is saline. So we use in this situation I'll take 4 contrast and 4 mils of saline. And we normally use the 20 cc to withdraw saline. Okay, so I like to use a baby connector when doing a PTBD. This helps to prevent movement of the needle. Okay. Once it comes out here, first thing you do, you straighten the tip and push the straightener. Okay. Then you tighten the hub and you connect the metal seal. Okay. You can remove the straightener and you can push. Okay, I think that's all from me. Thank you very, very much.
Very nice video. I nak nangis.
Macam video kahwin
So nice. Yeah. You've got lots of questions for this. I think, the first one, I think ID has answered. The simple one. Will PTBD be contraindicated if biliary ducts are not dilated? Maybe you can have your own answer. Can we do PTBD on non-dilated system?
Sometimes we need to do PTBDs on a non-dilated system. For example, if the patient has bile leak, like iatrogenic post-op ataupun post-trauma, patients will continuously has some bile duct injury and has continuous leak into the peritoneum. It's very dangerous if you leave it just like that, because patient can either develop a biloma, or patient who can develop bile peritonitis. So we need to help divert that bile from draining internally to we don't know where. So we have to externally drain it out. So we still have to attempt these kind of patients in a non-dilated system. It's more challenging, but usually it's macam a bit higher level lah. For beginners, normally kita tak adalah suruh buat non-dilated system. Selalu yang besar-besar gemuk-gemuk tu, itulah dia yang kita akan bagi junior buat.
Yeah, usually the gemuk is easy to puncture, but susah nak cross. Another one is dia tanya antibiotic coverage compulsory. I already answered for you. Compulsory unless they are already on antibiotics lah.
Yes, betul.
Kan?
Because there's a high risk of cholangitis,
Yeah, and then we seen so many patients develop prurigo on fever. Anim, I think they want to know, when do we use biliary ring catheter, and is there an advantage using the biliary ring catheter with pigtail? Abir and Abdul Hadi.
For me, my practice, usually we use drainage catheter biasa je, because we're quite familiar with biotech. We kind of like that it's very slippery, it's silicone based. But what we do is we modify the biotech drainage catheter, so we cut more additional side holes before we insert the catheter into the patient.
The biliary ring tu, sometimes the manufacturer develop a bit of angle lah, supaya dia stays in the duodenum, and there's more side holes. But if you have drainage catheter, as Dr. Anis said, you can always put holes. Alright. Hi, Dr. Anis. Want to ask, when we do cholangiogram, if air bubbles, how to overcome this?
How to overcome air bubbles? You punya syringe preparation lah. Sebelum ni, you can always make sure tak ada bubbles. So your assistant, whoever that is, first assistant, second assistant, always can make sure syringe tu.
Yeah, and then kalau banyak sangat air, position the patient or just push a lot of saline or something like that lah. Tak apa, dia non-vascular system. Okay. Can we do PTBD without ultrasound under fluoro guidance?
Boleh, tapi I can't remember the last time I did fluoroscopic guidance. I think macam like 5-6 years ago kot. Nowadays
I usually do the right side using the PTC, then convert to PTBD kind. But the left sided is always ultrasound guide. That's the usual scenario lah. So basically you can do find your cholangiogram, and then after that find the best duct that you can puncture. Usually is the usual segment 6 kan, sebab dia very dependent, as Dr. Anis has demonstrated. But the answer is yes. Okay, can we put stent immediately after PTBD, or you should wait?
I think it depends on the patient's clinical condition. Kalau kata the obstruction is not so bad, the system is not too edematous, you can put in the stent immediately. Especially if you're desperate, like the hospital tengah COVID, or katil tak cukup, nak kena discharge patient cepat, then you can put in a stent immediately. But I prefer to wait a few days, because usually during the initial part of the drainage, the system is usually very edematous. So what can happen is that you might wrongly measure the size, because you initially anticipate you measure dengan an edematous system, and then once the cholangitic phase is over, the system is less edematous, then there is a risk of the stent being a bit smaller than the initial measurement, then it might migrate.
Okay. Safura asks, what influences whether you do right or left lobe puncture?
It depends on where the pathology is, and you also have to be discussing with your surgeon lah, or the referring physician what is their future plan. Sometimes if the patient has a tumor on the right side, and the surgeons might have a plan to, they want to perform a right hemihepatic and they want to conserve the left. So some of them would want to okay, you drain the left so that we can save the left. Some of them would hey, don't drain the left because I don't want you to kacau. It's a very nice liver. You kacau the right side je. So again, it's a discussion and it varies depending on patient to patient.
Yeah, and kalau 5 o'clock on Friday, whatever gives you the access.
Yes.
Yeah. Alright, so it doesn't matter. Next one is, hi Dr. Anis, when we do PTC, a segment 8 will opacify first. Or is it depends on initial puncture? I'm not sure. Yeah. Yeah.
That one depends on your needle puncture satu, because you have to understand the needle the biliary duct anatomy jugalah. So whether it's an anterior or posterior duct. So let's say if you do a PTC, you puncture the segment 5, it's an anterior duct. So kalau you puncture segment 5, then dia senang for the contrast to flow back into the segment 8 and into the posterior ducts because of its gravity dependent. Whereas kalau kata you puncture segment 6, it's a posterior duct. So dia macam susah sikit usually for the segment 8 to be identified, to be opacified. Same goes with the left side. So kalau kata it's a non-dilated system, you puncture right side and then you inject contrast, you tak nampak to the left, then you tak nampak contrast going to the left, don't immediately assume that the left side is obstructed or there's like a hilar blockage, because again it's going against gravity. So what you can do is bila you buat cholangiogram, turn the patient to the left and you should be able to see the contrast going into the left if it's not obstructed.
Next question, the last two question is, what is the common duration of antibiotics? Do you give stat dose or 24 hours? And do you usually advise continue antibiotics post PTBD?
If the patient has never had any antibiotics, I bagi stat dose just before, within 1 hour pre-procedure. But usually these patients will be cholangitic and they've already been on some sort of IV antibiotics already. And then post, kalau kata patient has not been on any antibiotics, maybe I'll do for another 3 days, 2 to 3 days, maybe IV, and then depending on the patient's clinical condition, kalau patient getting much better, can convert to oral, 5 days cukup dah, then can stop.
Which side, Hanan tanya, which side of biliary duct yang have more complication? The right side approach ke the left side approach?
For me, I rasa the left side is more technically challenging because it's in the epigastric region and you have very small area to play around with your ultrasound probe and your needle, and that also means that your needle angle going into the duct is going to be more acute as compared to the right. You have a lot of space to play around with and you can flatten your needle well. So the left side, then you tend to have a very acute angle. So masa tu lah, that's when bila you nak masuk your dilator, you nak masuk you punya sheath tu semua, that's when dia senang terdislodge.
Yeah, I usually do the left kalau dia banyak sangat ascites, and the top left lobe tu yang paling atas, paling kurang sekali lah IA, because IA goes down kan. Usually I do that on the left. Alright, what's the difference between sheath and dilator?
Dilator, as the name says, it's to dilate the tract lah. So normally dilator, you just masukkan untuk gradually besarkan jalan yang you nak masuk in order to place a sheath. So sheath tu macam it's like a portal lah. So once you dah masuk kat situ, so you dah ada pintu untuk senang you nak keluar masuk. So it secures your access. So it's two different things. Normally we put in a dilator to prepare the tract in order to put in a sheath.
Okay, alright. Okay, nanti you go through the Q&A if you can answer